And so we need to keep moving with Dr. Ankit Mehta, our nephrologist, to give a talk about Fabry disease in the kidneys. So good to see you again.
Good seeing you.
All right.
Thank you very much.
Thank you.
Hi, everyone. So anybody want to tell me why I picked this picture? What do you guys think? Yeah, can you speak up for everyone, please? Just because you hear hooves doesn't mean it's a horse. And that's what rare disease is like for a nephrologist. Because from a kidney doctor, Fabry is the zebra. Fabry causing kidney disease, if I see 1,000 patients in my clinic over the next 2 years, maybe I will have one Fabry patient, maybe. So that's the biggest thing that I want to drive home, that most kidney doctors, when they're seeing patients for kidney disease, Fabry tends to be very, very rare. Now, I completely understand it's not rare when you have it, so you're going to have to educate your kidney doctor on Fabry disease. That's my first take-home point. So my name is Ankit Mehta. I'm a kidney doctor from Baylor in Dallas. I got interested in Fabry disease because when I was a fellow in training, I saw somebody who was getting a kidney biopsy in their 40s and getting diagnosed with Fabry disease, but had symptoms since he was a teenage boy. And I was shocked that somebody who would have symptoms for 20, 25 years still didn't get a diagnosis till they had significant kidney involvement. So that's what really got me interested in Fabry disease. And I'm going to try to go over some of the key aspects from my standpoint. These are my disclosures. So I have some more audience questions. What is the best way to look for early kidney involvement in Fabry disease?
If anyone has an answer.
C.
Wow, that's great, yeah. Another question. Regarding treatment of Fabry disease, which of the following is true? There is no specific treatment. Then you really were sleeping this morning. There is treatment available. It is too late if there's already kidney involvement. There's treatment available, but it is not shown to benefit kidney disease. And multiple Fabry-specific treatment options exist, but they have been shown to benefit kidney disease. That's awesome. Maybe I think I should stop and give you 25 minutes back, Jerry? No? Okay. Here are the quick things we're going to go over. First of all, what do the kidneys do? The kidneys are located in the back of the abdomen, right below the rib cage, so you cannot feel them. If somebody tells you that they're trying to feel the kidneys, that doesn't work. It's deep in the abdomen. You can't feel them at all. The kidney has a lot of functions. The first one on top is red blood cell production. So if you don't have good kidney function, you become anemic. So that's one first top line. The second one is regulation of blood pressure. So kidney doctors frequently become blood pressure specialists because a lot of kidney secretes a hormone which helps with blood pressure regulation. The third one is vitamin D and bone health. Kidneys activate the vitamin D, and so they're crucial to bone health. Fourth one is electrolytes. So anything you drink, coffee, water, tea, Celsius, whatever is in it, the kidney has to account for that, balance sodium, potassium, chloride, bicarbonate, but calcium, everything, and then make urine. So it balances all the electrolytes that the body needs to be in a balance for. And the last one, which is what most people are familiar with, is it filters and removes waste, right? On the right side, you see the common causes of kidney disease. If I made a list of top 10 causes of kidney disease, Fabry would not be one of them. If I made a list of top 20 causes of kidney disease, Fabry would not be one of them. So when you actually go to a kidney doctor and tell them you have Fabry disease, they're still going to look for other causes of kidney disease and make sure that's not the cause of your kidney disease. So I want you to remember that. A common question I get from my patients is my kidney disease due to Fabry disease? And that's a difficult question to answer because remember, there are hundreds of other things that cause kidney disease, which are way more common than Fabry is. So a lot of time it depends on a detailed history on what has been the course of other diseases, what has been the course of Fabry, what other Fabry end organ involvement exists. Is there heart disease? Are there other problems from Fabry? Is there evidence of white matter lesions on MRI of the brain? How severe is Fabry other places really helps me understand the kidney involvement. And then I would look for common causes of kidney disease. So I would screen for diabetes, screen for high blood pressure, and then do some lab tests. I also listed here an ultrasound. An ultrasound's helpful in only specific scenarios. Like if you're looking for kidney stones, it's very helpful, but many times it doesn't tell you the degree of kidney disease on ultrasound. Lastly, I've listed a biopsy. A biopsy is not done in all patients. It's done only if I know that the test is going to change my management and plan. So I'm going to go over some of the common tests for kidney disease. The first one is creatinine. Creatinine is a normal muscle metabolism product. So it's made in the muscles and the kidneys pee it out. So if your kidneys don't work very well, creatinine goes up in the blood. That's the best way to think about creatinine. It's made in the muscles normally, and the kidneys pee it out. The other one is urea. And when you look at your report, it's typically put as BUN, blood urea nitrogen. And that is a function of protein intake and liver metabolism. So it's made in the liver, depending on how much protein in your diet, it might change. But it's made in the liver, and the kidneys pee it out. Again, so kidneys don't work well, the level in the blood will go up because you can't remove it. A common one that I've seen being referred to earlier today is EGFR. Do you guys understand EGFR? I see a lot of no's. EGFR is a calculation that's based on creatinine, age, and whether you're a male or a female. That's it. 3 factors go into it. They used to be complicated with much more factors, and now it's simplified, but it's a calculation. But think of EGFR as a percentage kidney function. So most of us will start off at birth with 100%, so EGFR of 100, 110 is quite common. And then as we age, we start to lose a little bit of kidney function, so especially from the 40-year mark, we lose about 6 to 8% per 10 years. So everybody loses a little bit of kidney function from the 40-year age onwards, and that's measured in that EGFR. So you will see that number. All our reports now have EGFR built in. So you do a BMP, CMP, routine physical, you will have an EGFR. But we nephrologists classify kidney disease based on that EGFR number. So stage 1 is where kidney function is still normal, so EGFR is more than 90%, but there's some evidence of kidney disease. So protein in the urine, blood in the urine, albumin in the urine, some evidence that the kidneys are being damaged is stage 1. Stage 2 is, again, small reduction in EGFR, 60 to 90%, with evidence of kidney being damaged. Stage 3 is 30 to 60, stage 4, 15 to 30, and stage 5 is less than 15. Stage 5 is typically what we refer as kidney failure. Most patients will be on dialysis or needing a kidney transplant, somewhere around less than 15% EGFR. This is a visual way to think about the same thing. So from left to right, you're going from stage 1 through stage 5, and you have progressive loss of kidney function. And at stage 5, most patients will end up needing a transplant. A second way to look at kidneys is to look at filtration So normally, protein is important to the body, and the kidneys do a great job of holding on to it. If you find evidence of protein in the urine, that's a sign that the kidneys are being damaged. That's why we test urine protein, urine albumin. Albumin is the most important protein in the urine. There are others, but the biggest contributor to the protein in the urine is albumin. So we check urine protein creatinine ratio, urine albumin creatinine ratio, or just a simple urine dipstick where the nurse might just put in a colorimetric agent dipstick and give you 1+, 2+, 3+. That's just a urine analysis. In general, urine albumin, urine protein precedes GFR decline. So this is one of the earliest signs that the kidneys are being damaged before GFR starts dropping. Another common question I get is, are my kidneys going to worsen? So this is a chart that was made by an international kidney disease organization more than 10 years back. And on top, you see levels of protein in the urine. A1, A2, A3 are 3 levels of protein in the urine. And on the left side are stages of GFR. So stage 1 through stage 5, the GFR numbers that we talked about earlier. Just like a heat map, the darker the red, the worse the prognosis. So as you can tell, patients with high amounts of protein in the urine will have a much more rapid worsening of their kidney disease compared to patients that have less amount of protein in the urine. And that's why you will see that kidney doctors will be measuring this protein in the urine routinely. Also, patients with higher amounts of protein in the urine and lower GFRs are more likely to have heart issues. Remember, kidney disease patients all die of heart issues. So this risk factor characterization is very helpful because it tells me how aggressive I need to be to control those risk factors. I'm going to skip through some of this. End-stage kidney disease, or ESRD, or kidney disease where eGFR is less than 15, you can think of it as the best treatment for that is transplant. Kidney transplant patients live longer, live healthier than the patients that need dialysis. Dialysis is a way to clean the blood when kidneys are unable to do that. So there are 2 different ways of dialysis, and I'm not going to go into detail, hemodialysis and peritoneal dialysis. But better than dialysis is transplant. When we do a kidney transplant, we don't do anything to the native kidneys. And that's a common misconception. We don't take out the original kidneys and put in new kidneys. The new kidney actually goes on top, like just below the skin in right or left lower quadrant of the abdomen, where you can actually feel it in a transplant patient. And it's connected to blood vessels that go to the leg. So you don't take out the original kidneys, they stay in there. So the patient ends up with 3 kidneys, but only 1 working. How do you manage kidney disease in Fabry? So the first thing is Fabry-specific treatment. And I have a slide on Fabry-specific treatment, we can talk about that. But the other things are sometimes more important. Remember, kidney disease patients die of heart attacks. So we need to control the cardiac risk factors. That's why you see up there exercise, at least 20 minutes, 4 to 5 times a week of vigorous aerobic exercise where your heart rate is actually going up significantly, not a walk in the park sort of exercise. Weight management, blood pressure management, cholesterol management, salt restriction, all of these factors affect the cardiac outcomes in kidney disease. So that's why there's so much emphasis on that. And then from a kidney perspective, stop all NSAIDs. NSAIDs are this group of drugs that are over the counter: aspirin, high dose, Aleve, Motrin, ibuprofen. They're all NSAIDs except Tylenol. All the over-the-counter pain medicines are NSAIDs. And when taken at high doses routinely, they can cause kidney problems. So stop NSAIDs is a big part of kidney management. And then adjust medications for the degree of kidney disease. So remember, kidneys are what filters and cleans out everything. So if your kidney function is now down to 30%, you need a lot less medication because it's going to hang out a lot longer in your body. So your pharmacist and your doctor should be adjusting your medications to help account for that drop in kidney function. And specifically to slow kidney disease progression, I have listed some things over there. The first category is ACE inhibitors, and these are medicines like enalapril, captopril, lisinopril. They're generic. They're blood pressure medicines that help the heart and the kidney. The second category I've listed is the ARBs. These are losartan, candesartan, valsartan. They again also help the heart and the kidney. So you should be on either ACE inhibitors or ARBs, not both, but one of the two groups. And then the SGLT2 inhibitors. So these are Farxiga and Jardiance are the brand names. But these have been shown to help kidney disease progression in patients without diabetes too. They came out as diabetes drug, but they work in patients without diabetes for kidney disease progression and cardiac mortality in kidney disease patients. And the last one I have as a question mark are GLP-1s. These are Ozempic, Mounjaro, Zepbound, Wegovy. There is some early indication that it might help all kidney disease patients. We just don't have good data in Fabry specifically at this point, but that might be the next level of medications to help change kidney disease course. And if kidney disease still progresses in spite of all of this, then we talk about transplant before ever needing dialysis. So I start having conversations about transplant at GFR of 40, because I want my patient to have a donor ready and lined up that before they actually get to a GFR of 15 or 10 when they actually need dialysis, they have a transplant donor ready and they can get their transplant kidney and never actually need dialysis. That is a much better course than actually going on dialysis and then getting a transplant. I'm not going to spend too much time on the Fabry-specific therapies. I know you guys are very familiar with these, but they're listed up there, highlighted. How do we choose a therapy is very individualized. This is just something that some of the factors that I came up with on how to choose a Fabry therapy for your patient. So GLA mutation, amenable or not, age, kidney function, patient preference, oral IV, insurance coverage, which a lot of times plays a big role in this, and availability of clinical trials. This is my monitoring plan for patients with Fabry disease. I know there are some other Fabry experts in the room and they may disagree with some of this, that's fine, but this is something that I came up with and what needs to be checked. I'm not going to spend too much time on that. If your doctor is doing what's on top right side, that's wrong. Why is that wrong?
It's not all in your head.
If you put a stethoscope on the head, you can't hear anything. There's a big, skull. There is no such thing as listening to the brain. You listen to the heart and you listen to the lungs.
I thought you meant when a doctor tells you what you're experiencing is all in your head.
No, that's true too, yes. A lot of times what's ignored is the supportive therapy. The supportive therapy is almost as important as a Fabry-specific therapy, if not more, because a lot of these other organs have challenges that needs to be dealt with as well. So I made a list of a whole bunch of supportive therapy things. It starts with the kidney stuff. So from the kidney standpoint, the goal is to reduce protein in the urine. So I'm using those medications I talked about earlier, like ACE inhibitors or ARBs, and then SGLT2 inhibitors to try to reduce the protein in the urine, slow the decline in kidney disease. Blood pressure management, and then eventually dialysis transplant if this still progresses. I have listed the heart failure medications, and I know Dr. Jeffries talked about some of that. Pain management, stroke prevention, whether there should be aspirin or Plavix, but some form of stroke prevention. GI symptom management is a challenge. There are a whole bunch of medicines that are, I should say, trial and error to see what works for you, because the same thing doesn't work for everyone. And then depression and anxiety management. That's another thing that needs to be discussed at every visit. So you really need a team to work with you. Somebody recently asked me, do I really need to see so many doctors? And the answer is yes, but with one caveat: your doctors need to be talking to each other. So the geneticists and nephrologists and cardiologists and neurologists, they all need to be in communication and figure out what is the best treatment, because one specialty cannot manage Fabry disease well. One specialty can manage, but they can't do it well. So that's my part.
All right. Thank you, Dr. Mehta.